today's episode, we're going to talk about bleeding and HRT. I'm Dr. Davidson from Progress Your Health.
And I'm Dr. Mackey from Progress Your Health. So this question we received from Victoria, and this one, like I said, this one is about hormone replacement and bleeding issues. This is a little bit of a longer one, so why don't you go ahead and read the question?
I'll dive right in. Hi, your podcast is awesome. Thank you for making it available. I turned 50 4 months ago, still menstruating monthly, every 27 to 28 days, with exceptions see below. Generally feeling good, no hot flashes or night sweats that I can tell, sleeping 7 to 9 hours a night, might wake up once or twice on occasion, but able to go back to sleep quickly. My brain is working fairly well and my mood is good. No vaginal dryness or libido issues thus far. For reference, my mom had her very last period 4 months after she turned 54, and she has never had a hot flash. For the last 2 years, I have been taking 100 milligrams bioidentical progesterone from day 14. Sometimes I might start it on day 12 or 13 of my cycle if I feel PMS-like symptoms. I also have been taking 1.5 grains of compounded thyroid, T4, T3, for the last 2 years. I can honestly say the progesterone and the thyroid medication has saved me from a lot of suffering I had started to experience 6 months before I started taking them. I had just turned 48 and I had started to gain weight, couldn't sleep, felt depressed and brain fogged. And after starting the progesterone capsule and the compounded T4, T3 thyroid medication, I gradually returned to feeling normal again. Lately, I even managed to lose some weight I put on. My issues right now are my period. Although still regular, it's characterized by long bleeding. I can bleed for up to 14 days. Granted, the bleeding will lighten up after day 5 or 6, but it will continue at least as many days, but it's light. And to cap it all off, this month I finished bleeding on day 14 and started bleeding again on day 19. This is the first time my cycle is this short for as long as I can remember. I do yearly vaginal, transvaginal ultrasounds, all normal. My last one was earlier this year in June. Questions. Could I manage the bleeding by starting the progesterone earlier in my cycle? If so, on which day? Or do I need to start adding in a bit of Biest estrogen into my regime? My doctor suggested that I introduced 2.5 milligrams of an 80-20 ratio Biest from day 5 to day 25, but I am unclear on how this could solve the bleeding issues. Lastly, I'm experiencing some joint pain and joint inflammation lately, and I kept reading that could be a perimenopausal or menopausal symptom. Could adding a bit of Biest also help with the joint pain? Oh, and my skin is also drying up and sometimes breaking out a bit, so I guess that's related to the change in hormones. But it's the bleeding and the joint pain that I'm mostly bothered about. I already have low iron levels as it is, and it's hard to keep on top of them with the amount of blood that I'm losing each month, so your input on that matter is greatly appreciated. And then she does have a bit here about her hormone testing and lab testing that we could get into later if we needed to. But she also goes on to say, or Victoria says, I eat a reasonable diet, low carb, nothing processed. I fast for 16 hours and exercise reasonably, definitely not killing myself at the gym. So I think that's all helping, and I don't have much stress in my life, and that is super helpful too. Anyway, hope you have all the info needed. Look forward to answers. Thank you very much.
Yeah, well, that's a one that we hear quite often. So 50, still menstruating, having kind of, the proverbial irregular periods.
Or not irregular. She says they're regular, although this last time it started on day 19 instead of day 1, but that they're heavy and long. I mean, 14 days, that's like bleeding half of them, 50% of your life.
Sure. Well, I wonder why she, and maybe that's what her question is, she's using the progesterone from day 14 back to her period. I mean, we use oral progesterone all the time. We just use it all month most of the time. However, she's sort of right. The woman's body actually doesn't make any progesterone the first 2 weeks of the cycle up until ovulation. That's when progesterone production actually starts. So in some ways it does make sense kind of following in the normal rhythm of the body. But in her case, she could probably use a little progesterone all month long.
Yeah, I think you're right. In a perfect 28-day cycle, you have your period from day 1 to day 4, maybe day 5, and then the estrogen will spike on day 12. You'll have an ovulation on day 14. Like I said, this isn't a perfect cycle. But on day 14 is when you start to make that progesterone, and then if there's no pregnancy, then you have that, then all the hormones drop and then you slough the uterine lining back to day 1 as a period. So in theory, that's been the theory is, if you're going to take progesterone, take it from day 14 to day 28 or day
Right.
1 when you start your period. So it sounds good in theory. And there are a lot of women that actually do really well with that. But you can tell with Victoria, she's 50 and she's having a period. So she's definitely making her own estrogen. And a lot of us women do kind of follow in part with our mothers before us on when we're going to go through menopause. So she's definitely making estrogen, but that's kind of the hallmark of perimenopause going into menopause is you're not really making any progesterone. So that lining of that uterus is probably getting pretty thick. It gets a little sloppy because progesterone helps the architecture of the lining of the uterus stay nice and solid and solidified. So it's probably a little sloppy. So she has this heavy period and then it just kind of lingers and spots for days that I really think she's still at what you would consider either a little bit of an estrogen dominance or maybe a little bit more progesterone insufficiency that, like you said, just add in a little more progesterone.
Yeah, you can't really do much about the estrogen side, right? Because her body, her brain and her ovaries are still communicating, right? So she's on her own clock as to when her estrogen is dropping. Now, granted, because her period is changing, and because of where she is, we can assume that both her estrogen and progesterone are dropping. But like you mentioned, it's more disproportionate. She still has plenty of estrogen, otherwise she wouldn't be bleeding, but not enough progesterone to sort of balance that out.
Yeah, no, exactly. So the reason I really did like this question is I want to get into, because this is really common, where women will just, when they're kind of in that perimenopause or even sort of that sort of gray area between perimenopause, just going right into menopause. You're not quite perimenopause, but you're not quite menopause. You're like right in that gray area that it's just like this spotting and it's, it's annoying. So that is kind of what I liked about this question. And then and Victoria obviously knows her stuff because she said, she's asking about this and she's very specific that she was mentioning that her doctor wanted to add Biest, which is a combination of estriol E3 and estradiol E2. So he wanted to add, or he or she wants to add estrogen into her picture, which, like she said, I'm unclear on how that would help with the bleeding. And she's right, because it probably could exacerbate the estrogen that she already is making herself and cause that lining to get even more thick.
Well, now I agree with that. So you have to be careful with the dosing. I'm not sure if 2.5 milligrams right off the bat is the right dose, but it's almost like a paradoxical effect because sometimes you give one woman estrogen and she bleeds more. Mm-hmm. You give another woman some estrogen, Biest, and it actually does kind of realign her cycle and it kind of smooths everything out. But you can't really predict on which woman that's going to be. Mm-hmm. So the 2.5, do you agree with the 2.5, or would you give her estriol only, or you use a different dose?
I would probably, because she's not having any hot flashes, she's not having any night sweats, which are pretty hallmarks of, low estrogen.
Yeah, lack of estrogen,
brain
right?
fog, the information's in my brain, but I can't get it out. I can't remember the name. I can't remember the word, dropping words, that's an estrogen issue. Then you'd say, okay, maybe she would do well with just a little bit of Biest. Probably not 2.5 milligrams,
to start anyways.
I would
a little
even,
bit lower.
like you had mentioned, maybe just do a little estriol or do a lower Biest with a 90-20 where there's 90% estriol and just 20, or 90% estriol and then 10%, just a little bit, like 10% of that estradiol. So maybe a little to, like you said, kind of smooth it out. But I would definitely start by raising up her progesterone, probably maybe even a little bit more, and doing it all month long, except for when she's having like that active bleed. Because that is the one thing about the endometrial lining is when you're having your period, you want all that lining to slough off so we can start back new and then grow it for the the next cycle. So I usually tell women, even if you're spotting, I usually say stop the progesterone from day 1 to day 4. Go ahead and restart it on day 5 or 6, even if you're still bleeding a little bit. But I always say just stop it for about 4 nights and then you can restart it. But I would definitely extend it back probably about day 5 to start that progesterone and maybe even raise it up a little. And then just to further complicate it, because you can do anything you want with hormones, is maybe do a certain dose from day 4 to 14, and then from day 15 to her next period, you go a little higher. So you're sort of cycling that progesterone sort of a little.
Yeah, you're giving them a lower dose in the first 2 weeks of the cycle, because a woman's technically not making any progesterone there. So if you give her the full dose in the first half, it might not make her feel great, but it could help with the control some of the bleeding. And then you increase it, like double it almost, so 50 milligrams and 100, or 100 and 200, or 75 and 150, and those two things. And we've done that quite a bit over the years. That seems to be, a woman seems, now granted, this is me telling women how their bodies work, but a woman will know if the higher dose of progesterone is too much or it's well tolerated. Just get this. How would you describe that? Do you know how to? Have you ever had that happen where you've taken too much progesterone and it makes you not feel the way you want?
Well, if you're taking too much progesterone, sometimes you feel a little groggy the next morning, a little tired, hard to get going, kind of fatigued. Sometimes even a little, feel like a little water weight, a little bloaty, a little puffy.
A little bloating. That's so I hear that women will say they feel like they're going to get their period, but it's only the first half of the month. They might feel a little bit of bloated, almost like some more classic PMS symptoms, like they're going to get their period, but they're still a couple of weeks away from it. Does that sound accurate to you?
Yeah, and then some women take higher levels of progesterone. They're like, I love it. It's amazing. I want more. So everybody's different. I would say, for Victoria, and like you were saying, is like 100 milligrams of the progesterone here, that's like a size medium. That's kind of like your go-to dose.
Your standard, standard starting point.
If I have some younger women, or if they're more sensitive, because people are a little more sensitive, we might start at 50 or 75 or 80. But 100 is pretty classic. That I would say that it's probably just needs to either back up that 100 to start on day 5 or day 6, probably day 5, and then right on day 14, maybe even raise it up to 150 or 200. Yeah. And I think because she is 50, but she did put I didn't want to read on, she was very, very verbose, and I really appreciate, Victoria putting all this information in. So she did put a lot of her lab information in here, and looking at some of the labs that she put on here, is she is more of a perimenopause rather than a menopausal woman, because her FSH is at 9, her LH is at 13. That is more, when you see somebody really going into menopause, you'll see that FSH closer to like 25 to 45. She's got it at 9. So that's showing that she's probably just going, from perimenopause almost into menopause, but not quite. But the symptoms, and we've always talked about, I love the labs, but the symptoms give us the most information. That's the nitty gritty, is the joint pain. That might be more of an estrogen issue, because joint pain because lower estrogen levels or fluctuating estrogen levels in perimenopause can create joint inflammation, which then could create, the joint pain.
Yeah, I did notice here too, she does, we didn't go through any of the numbers, but her reference rate, or her units she put on here, I think she might be from a different country. She said mum. So I wonder, does that make her British?
Yeah, on here, if you go a little lower, I didn't read that part. She said that she's, I think, in the UK. Where is it? Yeah, because she was so sweet. She said, hopefully you can understand these reference ranges, because I'm in the UK. So I know she said somewhere.
I didn't read that part. But I just noticed the reference ranges are different, and she put MUM and mum as opposed to mom.
So I live in Europe, so I don't have lab results and different measures, but it was, sweet. Yeah.
Interesting. Okay. Well, nonetheless, you can just convert the labs, the reference range, but they're quite a bit different depending on which lab it is. You'll see one number for what we use in the States versus overseas, or even in Canada, and they can be drastically different. So it's hard when you're used to one set of units on a lab to switch and understand what the range is for those other units. We ran into that a few different times, people getting the lab work done either in Europe or overseas somewhere. And it can be a little challenging to understand, because you get really comfortable. Like you said, an FSH level, hers is 9 or something. So anything under 10, that, like I said, that's a really good number. That means something. But now if that number was, the units were completely different, it would take that reference point, and it would kind of twist it around a little bit. It wouldn't be as easy to understand. So anyways, she did also notice, she's, which I thought was interesting, 1.5 grains of compounded thyroid. Now, she said with being in perimenopause, one of our little secret weapons is a little bit of progesterone, a little bit of compounded thyroid. That helps those women that are in perimenopause feel tremendously better. That's like a little secret weapon that they, it really helps them, kind of rebalance, recenter, raises up their energy, helps with their sleep, and reduces some of that anxiety and some of that irritability. I just thought that was interesting that she had such a nice response from something like that.
Yeah.
You and I've done that many times over the years.
No, I love the compounded, not so much the instant release, but the compounded T4, T3, which is what it looks like Victoria's on. 1.5 grains, that's kind of like our old school jargon. So that would be 57 micrograms of T4 and then 13.5 micrograms of T3 or triiothyronine. So that's a nice combination there, and that's not a super high dose.
No.
If anything, that's kind of like a size.
It's a good starting dose. So 1 grain of thyroid. So this is where it gets confusing. So compounded thyroid is a combo between T4, T3. 1 grain is 38 micrograms of T3, and then 9 micrograms of T4. 38 micrograms of T4, 9 micrograms of T3, and then you just use that math and you go from 1 grain to 2. So 38 and 9, 76 and 14 or 18, 114, 27, and then you can kind of go in between and do half grains.
But make it more complicated. The cool thing with compounded T4, T3 that a compounding pharmacy makes is you can do any microgram you want.
Right.
Like I have some people that might be on 57 micrograms of T4, but because they're so sensitive to the T3, I have them only on 9 micrograms of T3 instead of the 13.5 or 6.5. Like you can do any little change, which I think is so cool because then you can tailor it to the person. Because while humans, we're humans, we're still all so really unique and different.
Sure. Now, comparing that, a compounded thyroid dose versus, let's say, Synthroid or just a T4 only medication, you only have one hormone you're dealing with. If you use a desiccated thyroid like an Armour or something like that, your 60 milligrams is not the actual
of the
dose.
Porcine thyroid.
Whether it's an natural desiccated thyroid or the class of natural thyroid that people use, but they do it in milligrams, but it's still broken down in that 38 and 9 that I mentioned just a second ago. So it gets really confusing. So if you go up or down, you're changing both of those variables, like you said with the compounded. Each of those variables are independent, so you can change the T4 by itself, you can change the T3 by itself. So it gives you and I as the prescribers and the patient, it gives them a lot of flexibility. And you can really hone in on a dose. Instead of having to we've seen people over the years too, they take one dose on one day, they take a lower dose or a higher dose on another day, and they go back and forth. That's because one dose is too much and one dose is too little. You can really hit the sweet spot on a dosing level and then you just get to take the same dose all the time when you're using compounded versus some of the other commercial things. Anyways, that's we'll move on from that. We'll get back to
Victoria did go
Victoria's
into
question.
her lab work on the thyroid, and it looked really good because that is one thing when you're also noticing somebody with joint pain or perimenopause, like you said, check the thyroid because the thyroid can change.
Sure.
Our bodies are always changing, but she did put in her levels, which was really great, and they did look the T4, the free T4 and the free T3 looked really good. So I wouldn't say that the joint pain is coming from low thyroid because that's classic. Low thyroid does cause like this, just sort of like all over joint pain that kind of moves all over the place. Where for her, I think it's probably a little bit to do with the fluctuating estrogen in her cycle. So, like I said, in a perfect 28-day cycle, you have these fluctuations of the hormones, but perimenopause, the progesterone doesn't always come up. Sometimes that estrogen can shoot up really high on day 12, but then crash down, on day 16. That's why when you're doing blood work, you're just getting literally a second snapshot of their entire life, So blood work is really good to put in par with doing, the symptoms on there. So I would say definitely raising up that progesterone, maybe even cycling it a little bit, 100 milligrams earlier and, on day 5, maybe raise up to 200 on day 15, and then also maybe adding in a lower dose of Biest or just an estriol only to see how that helps with the joint pain.
Yeah, in a situation like that, you have to be a little careful because you're much better off starting at a lower amount and then gradually over a period of a couple of cycles to gradually increase it to see where her tolerance level is, because you just can't really predict. The estrogen that you add in could make it better, and now she's back to one bleeding per month as opposed to what she's been going through, or just shorten it up. Or it could just make it completely worse, and now she's bleeding all the time. You just can't really predict which one it's going to do. So you just start a little bit and then gradually increase that. She's going to feel better anyways because you're giving her some estrogen, but you want to make sure that it actually helps the situation as opposed to making it more complicated.
Because everybody's so different.
Yeah. Now, granted, she wrote, again, a lot of detail. I appreciate that. There's a lot to read there. Do you have anything else to add about Victoria's case? Or?
No, I really appreciate everybody that writes these questions. And it's really cool to get these questions from these listeners because they know their stuff. Like she's talking about the labs. She's talking about her hormones. We started in practice 20 years ago, and people didn't know. I mean, nobody knew, but now it's really nice that people are actually doing their own research and learning about this.
Yeah. Well, the internet, I think, has changed everything. When we first started out, the internet was, it wasn't that long ago, but, the early 2000s, there wasn't really that much. So things have evolved and changed, and all of our patients, they're very well informed. They know what they're doing. I think people are sort of advocating for themselves by understanding what's going on, and they want to know what's going on. So hence why we're doing the podcast, because we know there's lots of women that are looking for answers to these types of questions. And honestly, Victoria's is no different. Take the progesterone all month, see what happens. Maybe lower the bias dose or change it to estriol, and also again see what happens. That's the issue with hormone replacement in general. It's not a one size fits all. You just have to kind of tailor it because some of those things you just can't predict. So, any last final comments?
No. Thank you, Victoria. Thank you, everybody, for listening.
Yeah. Until next time, I'm Dr. Mackey.
And I'm Dr. Davidson.
Take care. Bye-bye.